So we now come to one of the anticipated talks on fetal and neonatal hydrocephalus, and it's Dr. Jennifer Ronecker, who is a consultant neurosurgeon at the Phoenix Children's, who's going to talk to us about this. This has been always, particularly the fetal and fetal hydrocephalus creates so much multidisciplinary work with the obstetricians, the PICU consultants, and I'm looking forward to your talk. Thank you very much, Dr. Ronecker. Yes.
Can you hear me okay?
Yeah.
Okay, perfect. And can you see my screen okay?
Yes, thanks.
Okay, awesome. So I really thank you, Naren, for giving me this opportunity to talk about this topic. I really chose this topic not because I do specific research in fetal or neonatal hydrocephalus, but really because our neonatologists have asked us to start coming up with a standardized protocol to manage these patients. And so I don't really have any relevant disclosures other than I currently don't do any fetal surgery. So just an outline of the talk. I'm going to talk a little bit about the background of fetal hydrocephalus, look at how we diagnose this prenatally, and then how we manage it both postnatally and prenatally. So fetal hydrocephalus is a big problem throughout the world, and it's great to be able to talk to so many different people of different from different countries. So I put in a couple of the incidences throughout the world, and I think the important thing to note is the differences in the makeup of the causes of hydrocephalus throughout the world. So if you were to look at Africa, there's about a 60% incidence of post-infectious hydrocephalus, whereas in higher income countries, that risk is, or that breakdown is really pretty negligible for post-infectious hydrocephalus. And the non-African low and middle income countries, it's about 30% post-infectious. Mortality rates for fetally diagnosed hydrocephalus or just ventriculomegaly in general is about 40 to 50%. That includes, though, patients or fetuses who've been terminated, and those that have died for genetic conditions and other associated abnormalities. If you look at the postnatal mortality rate, that's only about 10 to 20%, which, that's pretty high considering what we have available to us to treat this. 50% of patients with fetal hydrocephalus have additional CNS abnormalities, with the most common being agenesis of the corpus callosum, but also other things like absent septum pellucidum, neuronal migration disorders. And 10% of them have an abnormal chromosomal microarray or trisomy 21 or other genetic issues. 38 to 87%, I realize that's a very large range, but in the literature, that's what's quoted as the rate of shunt dependency after being diagnosed with hydrocephalus, both prenatally and postnatally. And with that, there's a 5 to 22% risk of shunt infection or rate of shunt infection. So something that we can work on as well. So to go into the prenatal diagnosis, obviously the majority of times patients are diagnosed using an ultrasound. It's cheap and it can diagnose pretty large problems, but you can see the quality of the imaging compared to what we have available to us postnatally is not quite optimal. By diagnosis, ventriculomegaly is mild when it's 10 to 12 millimeters, moderate when it's 12 to 15 millimeters, and severe when it's greater than 15 millimeters. But you can see in the graphic on the right that even some patients who are greater than 10 millimeters of ventricular width will still be considered normal, or they're in that. On fetal MRI, the technology is getting better and better, but it's not quite perfect just yet. Sometimes you can see that the brain signal is normal in T1 and T2, and you might only notice a difference in the DWI. So you can see that picture on the right, that darkness in like the basal ganglia area on the ADC map, and brightness on the like the B1000 equivalent. And so that can be a sign of fetal ischemia. Obviously, the younger the patient is, the less optimal the imaging can be, because the baby is very small at that time, but also because the fetuses are moving around a lot. And so when they are stuck in that large uterus and floating in amniotic fluid, it's amazing how much motion artifact there can be. Something I was confused with when I first started looking at the fetal MRIs is how smooth the brain looks when the fetuses are really young. And so I'm not sure, it looks a little cloudy on my screen, but this is just a breakdown of some of the sulci that develop over time, and at what point we should start expecting those sulci to show up, and what point it might be considered abnormal. So that can help in figuring out whether these patients have not only the ventriculomegaly, but any other like migrational disorders or anything like that. For fetal ventriculomegaly, about 50%, I think I had this slide in already, but 50% have associated CNS abnormalities and 10% have abnormal chromosomal. So looking at a couple of I wanted to focus more on aqueductal stenosis, just because of its the potential role for fetal surgery, and then we'll also look at post-hemorrhagic hydrocephalus. But for aqueductal stenosis, this really interesting paper kind of broke it down into 4 different presentations for fetal ventriculomegaly. So there's some patients who start out with severe ventriculomegaly in that second trimester, so when fetal MRIs are being done, and those patients have completely obstructed. And so those are also patients who have potentially other associated anomalies like thalamic fusion, cerebellar hypoplasia, some complete or partial third ventricular atresia. And so those patients, a lot of them either are born stillborn or go on to have high mortality rates. The second type is rapid progression within the third trimester. These are patients who have had partial obstruction and they've been able to compensate relatively well for a while, but then something changes and then they suddenly become worse. And those patients are going to be at high risk for having brain damage, having ventricular rupture, and having cystic changes in the brain, because they really haven't gotten used to changes in the ventricular size. The third type is a slow progression throughout the gestation. So these are those patients that are able to compensate through the whole pregnancy. And those patients are at low risk of having brain damage because they've kind of been able to compensate this whole time. And then the fourth subtype is where patients have stable ventriculomegaly the entire duration of the pregnancy. And that can be difficult to diagnose, but you can see on that picture on the right, this patient has ventriculomegaly, but you can see that there's an increase in the suprapineal recess. So that's an easier way to identify these patients in utero. Some of these patients are being referred to neurosurgery. So at Phoenix Children's, we are really only seeing the moderate to severe ventriculomegaly and obviously spina bifida patients. But I think it depends on the region, because there's lots of patients mothers who elect to potentially terminate the pregnancy depending on the state of the baby. And there are other places, that have post-infectious issues that become more of an issue later in pregnancy. So depending on what region you're in may have something to do with which patients are being referred to you. This study out of Korea looked at the referral patterns for fetal ventriculomegaly. They saw 44 patients, or 44 fetuses. 57% were associated with underlying abnormalities, and that kind of included everything. So patients with aqueductal stenosis, that was counted as an additional anomaly, or arachnoid cyst, or other obstructions, or things like agenesis of the corpus callosum. 11 of those patients, so about 25% of those patients, underwent surgery with 7 VP shunts, 1 EVD, 1 arachnoid cyst fenestration, one who had repeat LPs, and then a septostomy. And of those patients, there was one VP shunt infection, and that patient unfortunately passed away. And 10 of those 11 patients had associated abnormalities. Of those patients who just had isolated ventriculomegaly, all of them had normal development. And then 35% of those who had other anomalies had normal development. So pretty good outcomes. Now looking at some postnatal management, these are the patients who are the non-surgical cases. So most of these are going to be the mild ventriculomegaly. On the left-hand side and the right-hand side, these are two separate studies, but pretty similar information, where we see that the milder the ventriculomegaly, the more likely they're going to be normal, and especially in that left upper graph, the patients who improved, the ventriculomegaly improved, they were more likely to be normal. Interestingly, in this study, of the patients with mild ventriculomegaly, none of them ended up with worsening. And then on the second study on the right, there were some patients who had worsening of their ventriculomegaly despite being mild. So, other thing that's interesting on that right study is only 5 shunts were placed out of the 84 patients that were looked at. And these were only looking at mild to moderate ventriculomegaly. For patients with aqueductal stenosis, looking at, we all know about the ETV success score. In this study, though, by Stephanie Green, she looked at 41 patients with isolated aqueductal stenosis, and 29 of those were diagnosed prenatally. Of those patients, 51% underwent ETV, and they tended to be older on average, which makes sense looking at the ETV success score. The mean was 8.1 months versus shunts where the mean was 43 days. And 62% of those who had ETV underwent a repeat surgery, with only 2 out of the 11 having a repeat ETV. The others underwent shunt placement. It's interesting that there's no difference in developmental delays or epilepsy or ophthalmologic disorders or ADHD in the ETV versus shunt group. 59% of those were treated in the first month of life, and again, the majority were shunts. 41% were treated afterwards with a mean of 11 months. And again, it didn't really matter whether the patients were treated early versus late. They still had no difference in the same developmental delays, epilepsy, and disorders of ADHD. And then 48% developed epilepsy, and 78% were shunt dependent at their mean follow-up of 5.9 years. When we look at the difference between ventriculomegaly and shunts and ventricular reservoirs, really, there was not any difference in infection rate or conversion to VP shunt. So this study out of the HCRN had a set protocol for when to intervene with post-hemorrhagic hydrocephalus. And so for those babies that were less than 1,800 grams, the surgeon had the choice of ventricular VSGS or a reservoir placement. If they were between 1,800 and 2,000 grams, the surgeon could decide whether to go with a shunt or a temporizing reservoir. And if they were greater than 2,000 grams, then they went on to VP shunt placement. And those were patients who had their set protocol of an FOHR, the frontal occipital horn ratio, of greater than 0.55. And the abdomen was safe to be able to do a VP shunt. When the IVH had resolved, and if they were still tapping or they still saw that the VSGS was kind of functional and draining fluid, then those patients were converted to a VP shunt after being greater than 2,000 grams. They had 90% compliance from the surgeons of that protocol, so really, really great compliance. Looking at the results, 145 patients were enrolled. 28 ended up not needing any final treatment. 11 were shunted immediately. That means that they were either greater than 1,800 grams or greater than 2,000 grams. 4 of them underwent an ETV, and then 36 had the VSGS and 66 reservoir slice. And you can see that there was no difference in infection or conversion to BP. And looking at the post-hemorrhagic hydrocephalus, looking to see whether endoscopic lavage is helpful. I found this paper very informative about their protocol. And so looking on the right-hand side, they used a 0-degree scope. They inserted it using an ultrasound guidance, and then they irrigated up to 2,500 milliliters in these babies, going from the frontal horn in the ipsilateral ventricle. They would put an EVD next to the endoscope to irrigate in and remove the bigger clots, but then just continuously irrigating through the scope as well. And once the ipsilateral ventricle was washed out and clear, then they would move to the third ventricle, and then they would perform a subtostomy in order to put the contralateral ventricle. It was also interesting that they placed flow seal at the site of where they felt the germinal matrix hemorrhage was coming from, and then they sealed off the tract using this hemo patch. They did a re-lavage if they found that there's progression of hydrocephalus or still having blood clots. And in those patients, there's 46 total. Most of them only underwent 1 lavage, but you can see that there were 28% who had 2 and 26% who had 3. And 58% of them ended up getting shunted. So I think looking at this, it's not really looking at it as a way to prevent shunting, but potentially preventing needing to do VSGS or a reservoir. 21% was the infection rate, but that increased it as the lavages, number of lavages increased. So the infection rate with 1 lavage was only 4%. And 13% had a CSF leak, which was sutured and stopped after that. There was an increased risk with the number of lavages, but that was not significant. And there was a 6% rebleeding rate, and 50% of patients had failed the shunting within the first year. So after those patients were found to need a shunt, they were shunted, and they had a very high failure rate in that first year. And this was the DRIFT trial. And so that was the drainage, irrigation, and fibrinolytic therapy. This was stopped prematurely because of the increased risk of rebleeding. So they were injecting TPA, irrigating, and they basically put in an EVD in one area and a reservoir in the other, injected through the reservoir, and then drained out through the EVD. So there was a 35% risk of rebleeding. 38% though were shunt dependent. So that's a lot less than what we saw in that prior study. And there was a 31% rate of severe cognitive disability. And this was a randomized trial, so the 59% were severe in the control group. And the control was really just repeat LPs for a few times until they decided that they needed more, and they placed a ventricular reservoir with repeat taps through there. And there was a non-significant lower rate of epilepsy in the DRIFT group. So, that study was prematurely terminated, but then they looked at the outcomes after 2 years, and they found that, in a separate study, there was an 8% rebleeding risk when they didn't use the TPA and they just did the neuroendoscopic lavage, and 59% were shunt dependent, so a little bit higher rate of shunt dependency. But they had great outcomes, and so there was a 30% of patients had normal cognitive development, 15% had mild delays, 11% moderate delays, and 44% were severely disabled. And data looked at GMFCS, which was 47% walking completely independently and 31% walking with assistance. So those are great outcomes as well. And 2/3 of their patients did not have epilepsy. And so the thought was that by washing out the blood, that they were able to kind of decrease any inflammation and like cytokine production that causes a secondary injury to the brain. These are the AA and CNS ped section guidelines that were created back in 2014. And so really they were able to say that these are the temporizing measures that exist. So the reservoirs, EVDs, VSGS, and repeat LPs. They did say that the VSGS decreases the need for daily aspiration compared to the reservoirs. They did not recommend serial lumbar punctures or intrathecal TPA. They also did not recommend Diamox or Lasix for reducing the need for shunt placement, whether it's something that people try in combination with other temporizing measures. They didn't comment on. There's no specific weight or like protein level to direct the timing for shunt placement. And there's really insufficient evidence to recommend ETV for these patients with post-hemorrhagic hydrocephalus. So we'll go a little bit into their prenatal management now. So the thought behind why fetal intervention can be helpful is that there are these patients who have, in their first phase of hydrocephalus, they had developed ependymal rupture, they have transependymal flow, and there's axonal swelling, but that could potentially be reduced over time or reversed. Second phase of brain injury with worsening hydrocephalus results in gliosis and demyelinization. And that's what they're trying to avoid by doing a fetal intervention. And so the thought is by doing an earlier treatment, this can potentially lead to better motor and cognitive outcomes. This was an interesting study from Brazil. There's a total of 39 patients who underwent prenatal treatment for hydrocephalus, and that was for a variety of different reasons, including aqueductal stenosis, but some communicating hydrocephalus. And so they placed a total of 18 ventricular amniotic shunts. They did 20 patients who had repeat cephalocentesis, so they used an ultrasound-guided needle aspiration of the ventricular system. And one patient had an ETV, and it was interesting. They put in their protocol for that. So they used a 2.5 millimeter needle, and they inserted a 2.3 millimeter flexible endoscope, and were able to, under ultrasound guidance, get access to the ventricular system and actually perform the ETV, and then widened the ostomy with a 2 French Fogarty balloon. And that patient, well, actually almost all of them, so all but one patient required a postnatal VP shunt, and including the patient who underwent the ETV. And of their patients, there are 39 patients, they reported that 26 of them were normal, 6 of them had a mild or moderate handicap, and 7 had a severe handicap. So really great outcomes. I wish, in the US, we're not able to go through this type of study just yet. And we're really more, the places who are doing it here are really more into like animal models at this point. But it was very interesting. So a lot of the papers that I saw on fetal intervention for aqueductal stenosis were by Stephanie Green, and I saw a really interesting talk by her at ASPN this year about her sheep model and everything. But they described using a percutaneous ultrasound guided placement of a ventricular amniotic shunt, and she did a great job in describing exactly this shunt that she's designed. But it's a one-way valve. It's a low profile to minimize the risk of uterine and membrane puncture when it's being placed. And these fetal sheep, rather than being injected with kaolin, which can migrate and cause inflammation, they've been using bio glue that goes directly into the system. So it creates more of a stable obstructive hydrocephalus. And they found that there was tissue ischemia and mechanical axonal shear in the non-shunted brains, and that was not present in the shunted brains. But they're still working on further studies looking at the safety of that device. But the thought that is that, based on, again, this paper that we discussed earlier, was that we're trying to prevent that rapid progression phase in the 3rd trimester where patients or the fetuses have really not had a chance to like get used to, or they've gotten used to the ventriculomegaly for a certain point, and then something happens and they decompensate really quickly, leading to that ventricular rupture and bleosis and cystic changes. And so the hope is that by intervening before that happens, they can potentially have greater outcomes. So just to wrap it up, I think there's still a lot of work that needs to be done to figure out really what is the very best way of managing these patients. But we've had a lot of data so far that shows that we're doing something by placing these VSGSs and ventricular reservoirs for post-hemorrhagic hydrocephalus, and ETVs can be very helpful, especially if the child is older. But we still have a lot of work to do in looking at how those patients do long-term, and then also looking at more animal studies and eventually human studies looking at the fetal ventricular amniotic, because there's some promising results so far. So that's it. Thank you.
Thank you very much, Dr. Ronecker, for that extensive and comprehensive coverage, which is very, very useful for all of us to know and be aware of the papers. And can I please bring Professor Deopujari? Sir, your questions for Dr. Ronecker and any comments? Thanks.
I think it's an excellent overview of prenatal as well as postnatal care for hydrocephalus. What I was wondering was that you showed several methods for postnatal care of hydrocephalus due to germinal matrix hemorrhage, which seems to be one of the common apart from post-infective in our part of the world. And there are so many studies going on. How do you synthesize? What is your current policy of treating them?
I think that's a good point, that there are so many different techniques and so many different protocols, and it's hard to combine everything into one. I think all of the experts on the PED section guidelines, I trust very much, and so I would plan to follow those guidelines of VSGS versus reservoir. They're pretty equivalent, although there's less chances of infection maybe with tapping, although some studies don't show that that's the case. But I think developing more of a standardization of at what point you intervene is going to be important for us, because everybody kind of has their opinions or their gestalt of yep, those are pretty big ventricles, but having a point at which you want to say, the FOHR of being greater than 0.55, I think is a good reference point to decide at what point you're going to do something temporizing or that VP shunt placement. So looking at, that's what I plan on doing at this point, is going with the FOHR greater than 0.55, and then looking at the weight, obviously. And here we tend to do shunts at either 2 or 2.5 kilos.
So most of the guidelines, as you have shown, are negative guidelines, except for the subgaleal shunt, which seems to work, and probably now 2-year follow-up with lavage, which seems to produce a little better result, but still doesn't give us a clear idea. So we've been following lavage in some patients, but mainly I think ventricular-galeal shunt is becoming, subgaleal shunt is becoming quite a common procedure in our part of the world.
Yeah, we don't actually do any VSGS at our institution. We've always just done reservoirs, but looking at the data, I think I would want to try at least to see how these patients with VSGS do, because it seems like, outcomes wise, things are the same and infection rate probably is the same, but not having to access a reservoir every few days, I think would be helpful from just a workforce perspective.
While we are on the VSG shunt, Prof, one of the complications is said to be multiloculated hydrocephalus from blood going back into the brain, into the ventricles. Do you see that, Prof, in your practice?
Well, I mean, I do not think it is particularly associated with the subgaleal shunts, but multiloculated hydrocephalus is fairly common. I think you see almost half the patients with either post-infective or post-hemorrhagic hydrocephalus ending up with needing fenestrations before you actually can put shunts.
Thank you. Thank you, Prof. Can I come to Professor Ricardo Santos de Oliveira? Thanks.
Thank you, Znari. Thank you, Jennifer, for your excellent review of the literature in terms of this subject. I have, in fact, I have two questions for you. The first is, if you received a family with a prenatal hydrocephalus diagnosis, what is your policy? What is your advice for the family, and how you manage the prenatal hydrocephalus in your clinical practice?
So I always tell the families that our goal is to get the baby to term as close to term as possible. There have been few instances where the baby's head has gotten so large, at which point then the OB doesn't feel comfortable delivering the baby, at term. They want to deliver earlier. But I always tell the families that would be our goal. We want to try to minimize the risks associated just with prematurity, with the lung maturity and everything like that. We are a freestanding children's hospital, so we don't have maternal, yet. And so my other goal with the families is to try to keep the baby with the mom as long as possible. And so that means, if the baby's born via C-section, the mom might be in the hospital for 1 or 2 nights. We can choose to observe the baby at their home hospital. And once the mom is discharged, and if there's any concerns, we can then transfer the baby to Phoenix Children's, or we could potentially continue to monitor at their NICU there. The nice thing is that we have most of our NICUs around the area are covered by Phoenix Children's NICU doctors, and so they're very easy to communicate with. And if there's any concern from their perspective of increasing head circumference or increasing hydrocephalus on their weekly ultrasounds, then they would be able to transfer very easily to us. Once they have an intervention at Phoenix Children's, then sometimes they're not ready for discharge yet because of being premature, and in those cases, sometimes we'll try to get them back to their closest hospital so that it's easier for the family to get to see them. So we try to focus on, making sure that the family can see the baby very easily, that mom and baby have a chance to do that bonding at the beginning, right after the baby's born, and so.
Okay, thank you. So it's very interesting, the paper that you showed about the prenatal ventriculomegaly, the natural course. So only 5 shunts was placed in more than 170 patients studied. It's a very interesting study. And when you compare, so you analyze the Brazilian paper, how can you see about this maybe a controversial result? So one is more for a conservative, or just few cases needed some treatment, and in the other hand, another paper showed possibility to improve the outcome of this babes after treatment. How can you analyze these 2 different points?
The difficulty with analyzing them side by side is they're not including the same, level of ventriculomegaly. So the conservative paper was only looking at mild and moderate ventriculomegaly, whereas the fetal surgery one was looking mostly at severe ventriculomegaly. So I think For the patients who have severe ventriculomegaly and potentially have aqueductal stenosis, I think those are where those patients are going to potentially benefit the most from some sort of fetal intervention. Those are the patients who, their brain otherwise should have been normal. So if we can prevent that secondary injuries, where I think we can see some change. But for those patients, like you said, with like more mild ventriculomegaly, the likelihood that those patients are going to progress or that they're going to need anything fetally would be very, very low.
Okay, thank you. Thank you for your.
Okay.
Thank you, Ricardo. Mr. Magdum, Shailendra, do you have
Hi.
a comment?
Yeah, sorry, I have to just be moved. So there's a postman at the door. But I think a great summarization. But if you look at the recent trends which are happening, which includes the UK-wide study of trying to standardize these things, and one of the things is that we have looked at the best indices to look at when to intervene is the Levine index. So you have to go for the 97 plus 4 millimeter percentile is the right time to intervene, because if you go more than that, then the cognitive outcomes are really bad. And that's the reason that you should probably standardize the Levine indices. Sorry, can I come back in a minute, please?
Sure, absolutely. We'll go to Dr. Satish Krishnamurthy. Dr. Krishnamurthy, you make a great point. Thank you.
Thank you. I was wondering if you consider protein levels in your management of these children, and I have been able to. There is about a 10 to 17% decrease in the need for a shunt in several different papers. So I wonder what your practice in your hospital.
We don't typically use protein levels, and is your question more
1 second, yeah.
at what point the protein levels are acceptable to do a shunt or to prevent shunt malfunction, or whether a patient even needs a shunt based on their protein level? Because I haven't quite heard that yet.
So we try to look at the initial protein level and decrease it as far as possible while we are waiting for the shunt, getting the adequate weight, et cetera. So I have used it and have been successful to get about 10-15% rate of no need for shunt despite a grade 4 hemorrhage. So we are analyzing a series of patients that we have treated like that in Syracuse to demonstrate that this is actually useful. We'll not be the first one to study this. This has been published before by many other investigators, but it's useful to prevent shunt dependency in the future.
Do you mind me asking what your protein level cutoff is?
Oh, I don't look at the actual protein level. I want to bring it down to as low as possible. And sometimes when you get it down to the 20s or the teens, the kid doesn't need a shunt. I leave the reservoir till the age of 1 year so that, I have a way to access the ventricle, and I have a way to get to the CSF without having to do an emergent borehole and take the reservoir off after 1 year or so. But I use it to decrease the protein levels. We don't have an actual measure. We are in the process of analyzing what is a good level, but we've been doing that for 4 years now.
That's interesting. Yeah, I looked a little bit into protein levels as far as shunt malfunction goes, and it looks like the consensus is it doesn't seem to matter what the protein level is, that's not going to increase your risk of shunt malfunction. But that's an interesting point, and maybe why the endoscopic lavage might be helpful, not only just taking out the blood products, but also washing out the protein.
Yes, as long as you don't cause more trouble. From the data you showed me, I think you cause as much trouble with the endoscope as you're trying to avoid. Yeah. So I would love to hear what Professor Sinali says about that. But I certainly, I don't have that ability to decrease the protein level with a lavage. I tried a couple times, but it was not very good. So
I think if I come in, our paper shows that the protein levels do dramatically reduce, because basically you're washing out blood and washing out the source of causing the proteins. And you can wash 2 to 3 liters. This is just not us, but there is another European paper which has confirmed that. And this has been we are doing it for 10 years now. We have the first series of 26 patients have been published, and the next 26 patients are in the pipeline to be published probably this year. And the outcomes are so good, and the shunt dependency rates are so reduced. Infection rate is again historical, but if you do it in a way that you don't have to have a curvilinear incision, you have a vertical incision which closes properly without having a subgaleal pocket of fluid which can leak and cause infection. So the techniques have improved, and you can wash even in 600-gram babies. If the anesthetist and the department is okay to anesthetize or make the baby to sleep, you can wash 2 to 3 liters of warm Ringer's lactate without any problem, with a careful, slow irrigation. And with a pressure of 80 to 90 millimeters of mercury, we have done that for the last 10 years. And it's the follow-up from the DRIFT trial, we took it on because we saw such a great result with that. And now what in UK we are doing is we are doing a randomized control trial with VSG, with external ventricular drains, with ventricular access device versus endoscopic lavage, is what the consensus is open now for recruitment. So it would probably give us the whole answer of what is the right thing to do. But this shows very promising results with not the similar amount of complications you used to see previously with this. And probably the loculated ventricles were a result of infection happening post washouts or post drainage or anything else. But if you do just a plain washout, it's very unlikely to cause loculated hydrocephalus. You probably reduce the chances because the protein content reduces dramatically.
so what is your rate of shunting with the lavage?
I will have to go to my paper. Just give me 1 second. We had I think we had about 40 to 45% of patients who did not need a shunt. So that is very, very important. And we have got a long-term follow-up because all these patients have been followed up with neuropsychology for all these years since we started. So we have got a very strong follow-up. Being NHS, we do not tend to lose patients. So everybody is in the system and followed up year-on-a-year basis. And one of
Impressive.
Yeah, thank you very much.
Yeah. Yeah, impressive.
Just to come back on the CSF protein and the shunt function, Professor Baiston in the Listserv had previously mentioned, and they have published that the CSF protein actually doesn't affect the shunt function. If anything, improves the shunt function. And I have been a big believer of this, and I had mentioned that too when I worked with Mr. Magdum when I was in Oxford. But subsequently, I have looked at the paper again and also listened to Prof. Baiston's talk. The thing is that they did this experimental study on using albumin, and whereas when you have a post-hemorrhagic hydrocephalus, the protein is not albumin. So whether that particular point is applicable to a clinical place is a question. So Mr. Shaindra Magdum, please give my correction to you and your colleagues, the qualification that I subsequently came across. So any thoughts on that? And you mentioned, Jenny, that you guys didn't feel any difference between protein and shunt function.
Correct. Yeah, there's been a paper from JNS Peds that also showed that there didn't seem to be any difference in shunt malfunction with different protein levels. But yeah, we don't typically follow the protein levels too closely.
That's great.
Now maybe I will though.
I think if you're, I understand that the protein gram is 2 gram or low, but if you've got a protein level of 8 gram, when you have got a tube which you put an external drain which gets clogged every day, so obviously the shunt is not going to work. So I think there is a leeway of how much protein can be acceptable, and from Indian studies with Professor Deopujari, we used to put shunts in tubercular meningitis with. We never even calculated the proteins when we did that. But it is something which we have to kind of look at with the technology of the shunt valve and everything becoming so precise that if there is a little bit of extra amount of viscosity, it is going to cause problem, because those valves are studied under a standard manner with a normal CSF viscosity. So we don't have anybody studying a shunt with high protein levels ever. So it's going to be a difficult thing to say that proteins don't affect anything, but I think it does affect, because if you have got something which is coagulating with significant high volume of blood in the ventricle, I think it is going to cause a problem. So you have to be just pragmatic and decide which is the right thing to do for patient. There won't be a protocol or standardized thing for a particular number of proteins, I would say.
I want to follow up on your comments, Dr. Magnum. What I feel is that the literature says about a gram for the shunt, but I think most people do the experiments with the shunt tube. I think the problem is the valve.
Yeah.
And recent programmable valves are terrible because they have such low caliber of openings that they're easily clogged, and plus the surface properties of the material used do not allow for the proteins to not adhere to the walls. There is another problem. If you put a Y shunt, the caliber of the connectors decrease by a fourth, which means the flow goes much lower. So all these problems should be considered when you're putting a shunt in a high protein ventricle. And I think we got, and that's why the Indian shunts work, because we don't use a lot of programmable valves there. And those valves are more robust in terms of transporting proteins across the valve. And I think these are some of the issues that I face in my practice. I usually put a regular valve, like a medium pressure valve, and be done with it.
Yeah, some of the valves are over-engineered to stop the gravitational extra drainage, and that is the problem with someone who has got abnormal CSF.
Just to come back.
We usually use a cutoff value of about 1 gram before we put a shunt. Anything above 1 gram, we are reluctant to put in a permanent shunt.
Just to come back, Dr. Krishnamurthy, we'll get Dr. Baishan to give a talk in one of the subsequent meetings. They did look at the actual a shunt valve with albumin, but once again, albumin is a clean albumin is not exactly a physiological or pathophysiological thing. But what they found with the albumin high level is that it actually improved the CSF flow through the valve. So it in fact improved the valve function than decrease it. But once again, I just want to stress that it's albumin rather than. Just coming back on this, Jenny, in terms of Dr. Satish Krishnamurthy's talk, do you think the CSF protein, because we always thought the CSF protein is going and blocking the arachnoid villi, and that's why it's causing hydrocephalus. Do you think that the high CSF protein level would be, again, going with what Dr. Satish Krishnamurthy said, the osmotic effect, as well as causing also to cause ventricular enlargement?
Yeah, I think I would have to defer to him as the expert. It's not something that I've looked into too closely in the past.
Dr. Krishnamurthy?
I think I'm biased, clearly. I think when you look at very low pressure hydrocephalus, I always ask the journal authors or journal article authors for their protein levels. Not many people have gotten back to me, but in the places where you see very low pressure hydrocephalus, usually it's mostly seen in adults where you have subarachnoid hemorrhage twice, and you have intraventricular hemorrhage that is repeated, and there is some compliance issues with the brain. They all have very high values of protein, and I think protein values do have a very significant role. If you look around and look at the experience of expert neurosurgeons that are in this group, like Dr. Magdum was saying, it is, you decrease the protein level really rapidly, you decrease the rates of shunts. And that should give us a hint on what mechanisms may be involved.
Thank you very much, Dr. Satish Krishnamurthy, but thank you very much, Dr. Ronecker, for that fantastic talk, giving us lots of points to think, and also for us to be abreast of all the breadth of the neonatal and the fetal hydrocephalus. So it brings us to the end of this webinar. This is the third one, and hopefully we'll have another one in 2 months' time. It has been a fabulous webinar, at least for me. I've learned a lot and left me with a lot more to think through. And I wish to thank the speakers with Professor Kinichi Nishiyama, Professor Chinali, and then Professor Satish Krishnamurthy and Dr. Ronecker, and also our expert panelists who have really made this a really fantastic session, and all the participants. Thank you, Professor Deopujari. Thank you, Dr. Jallo. Thank you, Dr. Ricardo, Oliverira, and Magdam, and all those who contributed. I hope you all found it rewarding, and look forward to having you all again in 2 months' time. Thank you. Bye for now.
Thank you.
Thanks, Naren. It's been a great experience.